Okay, ladies and gentlemen, I'm very happy to be here with you this afternoon. So this is a tutorial on how to personalize RT modalities in ICU. So this is an interactive session, and I would be happy if you have something to say about the case and the question on RT modalities. I have some conflict of interest because I have a randomized control trial funded by grants from French Ministry of Health and French Ministry of Research regarding different modalities of renal replacement therapy in the ICU. Okay, so let's start with a clinical case. Miss B. This is a 64-year-old woman present to the emergency department because of respiratory distress. She complains of weakness, fever, yellow sputum, production, and the blood pressure is low, the heart rate is high. She presents mottling, and the chest X-ray suggests a severe pneumonia, and the Legionella pneumophila urinary antigen is positive. So it's quite simple of case. So she's transferred to the ICU, and during the first 12 hours she received invasive mechanical ventilation, 60% of FiO2, the PEEP level is 8, and she received 4 liters of IV normal saline. Sorry, we are in France, we use normal saline, and we use a lot of fluids, probably. And the norepinephrine starts and until 3.5 milligram per hours, and there is an anuria. So I think this is a septic shock. There is no lactate here on the slide, but this is one. You can see here the lactate. The blood tests are here. So the creatinine level is 335 micromole per liters, blood urea nitrogen 26, potassium level 4.6, bicarbonate 17, and the pH is 7.32. So my first question, which statements is or are correct? The severity of the septic shock mandates to start RT. The acute kidney injury stage 3 KDIGO is an indication to start RT. And third, delaying RT initiation is the best option in these unstable patients with no life-threatening complication of AKI. Okay, so let's start. Who wants to say A? Nobody? Good. Who wants to say B? Ah, B. Possibly. Okay, I would say C. Okay, so we are going to wait. Sorry. It is not a case on a question on the RT timing, but we can discuss together after the tutorial if you want. I think that we can wait a bit. Okay, so delaying RT. So you know that now with a lot of evidence, with a lot of randomized controlled trial published in the last decade, we have now adopt a conservative approach to initiate renal replacement therapy. And in the context of severe AKI and multi-organ failure, the first question is there any life-threatening complication? You can medically treat this complication with sodium bicarbonate if there is a severe metabolic acidosis. If you want to see the BICAR ICU trial, this is a very interesting trial. The severe pulmonary edema could be treated by furosemide if you want, if it's possible. And if this life-threatening complication is refractory to treatment, you have to start RT. In the absence of this complication, you can wait probably until 3 days, because the AKIKI 2 trials show that after 3 days there is probably an increase in mortality. But before this, all the randomized controlled trial, including multi-organ failure patients in ICU, show that there is no problem, it is safe. You can wait. If you want to discuss hyperuremia, neurological symptom, we will have a discussion tomorrow on encephalopathy and renal replacement therapy in the afternoon. I will be happy to discuss with you. Okay, so Miss B, after 3 days, the norepinephrine dose is 1 milligrams per hour. You can see that there is a persisting anuria, the hypoxemia increase, FiO2 70%, the PEEP level is 10, no documentation of pulmonary infection, weight gain like French ICU patients. I say that because Rinaldo Bellomo showed us that we give a lot of fluid in France compared to United States and New Zealand and Australia. So probably our patients are more weight gain. You can see also that the sodium, the serum potassium is 5.6, so it's not a real emergency, but the urea is around 40 millimole per liter. So you decide to start renal replacement therapy. And my question is, which modality do you choose for Miss B? Do you choose intermittent RRT, peritoneal dialysis, continue renal replacement therapy, or hybrid techniques such as SLED, PIRT, all things like that? So let's go. Who wants to start with intermittent renal replacement therapy? Dr. Barrow? No. Okay. Peritoneal dialysis? Nobody? Okay. Continue renal replacement therapy? Okay. Hybrid techniques? Hybrid. Okay, hybrid. Okay. That's interesting. Indeed, we have a lot of choice in the literature. You can use peritoneal dialysis, why not? We'll discuss this, but we can also use extracorporeal renal replacement therapy. And it's probably our option today, but why not peritoneal dialysis? Okay. You have the choice, intermittent, the session duration is between 4 to 6 hours. The hybrid techniques, it's between 6 and 12 hours, and continue, it's 24 hours a day. Okay. But you know, probably you can use peritoneal dialysis. It's a very old technique. This paper explained the treatment of uremia after acute renal failure. It was in 1946, you can see. But in 22 years ago, this single randomized control trial showed that it was better to use hemofiltration than peritoneal dialysis in ICU. But few years after, this meta-analysis challenged this conclusion, because probably in this study, there is no difference in terms of mortality between peritoneal dialysis and extracorporeal therapy. So it is not totally excluded to use peritoneal dialysis. You can see the KDIGO guidelines state that, for example, in limited resource countries, you can use because it is very easy to use. It is associated with low cost, and there is a minimal requirement and infrastructure. Here you can see an example of percutaneous insertion of a catheter for peritoneal dialysis. And the experience of colleagues in the Saving Young Life program, an initiative to provide PD support in Africa and Southwest for acute kidney injury patients. A lot of patients were pediatric patients, and the result of this program is very, very good. If you want, there are some recommendations on PD, and I think that we discussed this point yesterday. I think we have to know how to do this, because in a world of constraints, with pandemics, natural disaster, climate disaster, poverty, wars, we have probably an option with peritoneal dialysis. And you can see that even in the United States, in New York, during the COVID-19 crisis, some of our colleagues in ICU start peritoneal dialysis because between 20 and 40% of patients, intubate patients, need renal replacement therapy. They have to initiate, in some patients, acute peritoneal dialysis. Okay, so we will not discuss peritoneal dialysis. We will now discuss intermittent or continue. You have a lot of choice you can use diffusion, convection, and both can be used with intermittent technique, intermittent machine, or continuous machine. And if we want to summarize this question, this is which modality should be used in our patient in the ICU. I will say that probably with patients with acute brain injury with a risk of intracranial hypertension, we should use continuous renal replacement therapy. There is no debate because of the risk with osmolality disorder. But we should also use intermittent in some of patients in the ICU, for example, patients with dialysable drugs or toxins, why not? And possibly with life-threatening complications such as hyperkalemia, because you will be better, you are going to be fast with an intermittent technique. But in the other case, even in case of hemodynamic instability, even in case in fluid overload, at this time, the debate is still open. And there are many controversies on this question. You can see that intermittent hemodialysis is associated with a lot of advantages. It's widely available, it's easy to use, it's better for transportation if you want to go to CT scan, the operation room. If your patient is with the continuum machine, it's quite difficult. It's better for rehabilitation. And this is absolutely not a detail. We know that the rehabilitation is associated with better outcome for our patients in the ICU. It allows a rapid correction of metabolic abnormality, and you have the option no anticoagulation option. Sorry. But the disadvantage, yes, it's possibly the hemodynamic instability. But is there anybody who can define instability, hemodynamic instability? What is it exactly? Every morning I heard the handoff, I say, okay, he say that the patient is unstable. What is it? Me, I don't know. Okay. But, okay, hemodynamic tolerance, we'll say. But you have a lot of strategy to improve the hemodynamic tolerance in your patients on intermittent hemodialysis. And we can play a game if we want. If you want, okay, let's go. Your objective is to preserve intravascular volume and to prevent hypovolemia during the intermittent RRT. What do you choose? What do you think you can do? This is probably the most interesting piece of my slides because it was published 24 years ago and nobody knows that. So, what is your option? Is there anybody to answer the question? You can use your microphone. No problem. You push the red button and you say, okay, I do that. Let's go.
Temperature?
Temperature, why not? But it's not the good physiological effect. Another thing? Let's go.
Dose and the size of the kidney you use. So
okay. Here are my answer, but we will discuss. The first is to use conservative ultrafiltration. This is the last one. For me, it's the most important thing. Why? Because it's probably the most important intervention to decrease hemodynamic instability due to renal replacement therapy. So we have to start with zero ultrafiltration, then gentle ultrafiltration. Then you can extend the session. A session of intermittent is not always 4 hours and 4 liters of ultrafiltration. This is the session in chronic kidney, in end-stage chronic kidney disease, not for our patient in ICU. Okay, and of course you start with a full circuit of saline, for example. So to preserve the vasomotor tone, what do you propose? Your microphone is open.
Oh,
Look,
sorry.
it's still open.
You'd continue your vasopressor infusion, and if you have a water unit on your unit, you don't need to transport the patient to the...
Yeah, but it's not the set of the machine. What do you do for the set of the machine? You had the right answer before.
Yeah, you use a smaller kidney, so
You reduce the dialysate temperature. It was your answer at the beginning. It was you. Okay, sorry. Okay, so you reduce the dialysate temperature to preserve the vasomotor sound. 1 to 2 degrees, it's okay. Next question, to preserve plasma osmolality and to prevent rapid shift in plasma osmolality, you think that it could be associated with hypotension? Somebody want to answer? Okay, I will do. So you can reduce the dialysate flow rate. It's very easy. And your dialysate sodium profile should be increased, probably 145 millimole per liters. And the last one is the preservation of myocardial contractility, and you should prefer bicarbonate buffer. So all these strategies are very simple to do. And the conclusion of this is that in ICU, if you want to use intermittent, you should provide intermittent, but you should not prescribe as in chronic dialysis unit. This is the publication of Frederick Shortgun 24 years ago in the American Journal. It was a before and after study, and with all this very simple intervention, they reduce the number of patients with hypotension during the session. So they improve the hemodynamic instability, the famous hemodynamic instability. But what do current guidelines suggest? If you look at this, KDIGO guidelines say, okay, you should prefer CRT for your patient hemodynamically unstable, It's 2.B, okay. But in France, continuous intermittence may be used equally, taking into account the experience of the team. And in this debate, this is a hot topic debate. Paul Palevsky, one world expert in renal replacement therapy, stated recently in critical care nephrology and AKI that's stating that intermittent and continue provide equivalent outcome is misleading if it is not acknowledged that similar outcome may not be achievable with the short, rapid treatments that characterize most inpatients hemodialysis in US. So you have to extend the session from 3 to 4 hours to probably 5 or 6 hours. Why not? And our colleague here, Dr. Barrault, says I want to use hybrid therapy. But he's a French guy. And for him, hybrid therapy is intermittent renal replacement therapy. But he cannot do this. He cannot say this because nobody will understand. But in France, we perform intermittent like hybrid treatments. We use gentle ultrafiltration, slow dialysate flow rate, and we extend the session for 5, 6 hours, sometimes 8 hours. So it's a kind of hybrid treatment. So the choice should be evidence-based because everybody here wants to start CRT in Miss B. Everybody, but probably not my friend. So the comparison should be evidence-based, mortality, hemodynamic, renal function recovery. And I'm very sorry, but there is absolutely no data who say that it's better for survival to start with continued renal replacement therapy. This is a first randomized controlled trial, the HEMODIAF trial, published in the Lancet in 2006 now. And you can see the mortality is absolutely the same between intermittent and continue. And I don't know if the patients were unstable because in terms of hemodynamic issue, because I don't know what is hemodynamic instability. But you should know that the vast majority of these patients had a lot of norepinephrine, just to let you know. And the mortality, you can see, was very high, 60%. So it was very severe multi-organ failure patients. And there is no difference between continue and intermittent. And here, this is a Cochrane review. They assessed the efficacy of continue and intermittent, including all randomized control trial on this question. You can see that at the end, there is absolutely no difference in terms of mortality. Only one study, the red one, you can see, but it is in favor of intermittent hemodialysis. It was a randomized controlled trial performed by Professor Mehta in San Diego. And so there is just one randomized controlled trial showing a difference between the two strategy, the two modality, but it was in favor of intermittent. And very recently, with some colleagues, we published this analysis of AKIKI and ideal ICU trials. It was a secondary analysis of these two randomized control trials. It was trials on RT timing, but we merged the two databases, and we include patients allocated to the early strategy in order to emulate a trial where patients would have been randomized to receive intermittent or continue within 12 hours after severe AKI. And the primary outcome was the 60-day overall mortality. We use a propensity score method. And the result of the study, it was published 2 years ago, is that the Kaplan-Meier death rate at day 60 was 54% in the CRT group and 46% in the intermittent group. So in this paper, CRT is associated with increased mortality. That is the result of the data, and it is published. And last year, we published with our colleague from Canada in START-AKI, Ronwald and Sean Bagshaw, because, you know, START-AKI was a multi-center international randomized control trial. And in France, we have included more than 700 patients on the 2,900 patients in START-AKI. So we discussed together to compare intermittent and continue in START-AKI. Do the same that we did in AKIKI and ideal ICU. And the result is that at the end, CRT was associated with a lower risk for a composite outcome of death and RT dependency. So this is the opposite result of our study in AKIKI and ideal ICU. This is quite interesting, but you can look at the results. It's quite interesting because it is probably clear that the result will favor CRT, but only in the accelerated strategy. The accelerated strategy, this is the early RT initiation strategy. And as you know, now, Ron Walsh and Bagshaw, everybody who performed this kind of trial will say that the best RT initiation strategy is now a delayed strategy. So the standard it names the standard. So you can see that probably in the standard, it's not so sure. So to summarize this kind of discussion with our colleagues, there is no modality of RT show clear superiority, but previous study provide conflicting results on renal function recovery. And we probably need more trials, including composite outcome. It will be the case. We have started the ICRAKI trial. This is a non-inferiority, multi-center, open-label randomized control trial, including very severe patients in ICU, severe AKI, with patients receiving mechanical ventilation and catecholamine infusion, so probably hemodynamic unstable. And the patient will randomly assigned to CRT or intermittent, and the primary outcome will be a composite outcome, including death and kidney function and RT dependency after 90 days. We plan to include 1,000 patients. We had just started a few weeks ago, and 100 patients are now randomized in the study. So you decide intermittent, continue, why not? Miss B, first session, my question, finally, somebody tell you, okay, start intermittent. Remember, Miss B, we'll try to do this. Yeah, Miss B, norepinephrine 1 milligram per hour, temperature 36, persistent anuria, weight increase 8 kilograms, blood urea nitrogen 40 millimoles per liters. So you are the doctor in charge. What do you propose for the duration of treatment? 8 hours. Toi, t'as pas le droit. 8 hours. Okay. Why not? Okay. I propose 2 hours. So we will say, wow, he say that I have to make gentle session, 8 hours, 12 hours. But there is one difference. This is the first session. And this is very important. Because if you start with the 8-hour session, why not? Even if you use low dialysate flow, the osmolality will decrease in few hours, relatively fast. And there is a risk of disequilibrium. And this risk exists, and it could lead to brain edema. It's possible. And in my clinical practice, and in many ICUs in France where we use intensive intermittent hemodialysis, we start with a 2-hour session to avoid this problem of disequilibrium in osmolality. And it's quite important because even if you use 8 hours, if you use a gentle dialysate flow, it will be probably too much for some of our patients. So we start 2 hours, and then the next day we say 4 hours, and then the next day we do 6 or 8 hours. Okay? I let you the set of the RRT machine. So hybrid, I say yesterday that hybrid therapies depend what you want. It's a kind of intermittent RRT done properly for our ICU patient. And the first who described hemodialysis, the inventor of hemodialysis, Professor Kolff. This paper was published many years ago, but at this time, Professor Kolff performed hybrid treatment, hybrid therapies. The duration of the treatment, it was 11 hours, 116 milliliters per minute. So the definition of hybrid therapy, it's a form of RRT that offers either diffusive or convective clearance that is longer than a standard hemodialysis session, 3 to 4 hours, but no longer than 24 hours. The treatment parameters are always very simple because it's between CRRT and intermittent. It's between. But, you know, now that in France we use probably more hybrid therapy compared to intermittent session we can use in chronic patients. So the advantage, they facilitate the performance of transportation, rehabilitation procedure. There is less need for anticoagulation. It is cost effectiveness. You can see that it's clear. And there is no difference here again in terms of mortality. If you want to compare SLED, for example, which is a real hybrid therapy, and CRRT. And the nursing time spent in the unit is less with SLED. This is probably very important. And for this reason, in a world of constraints, we can use intermittent, peritoneal dialysis, and hybrid techniques. So in my clinical practice, I have 30 seconds to finish. Within 24 hours, when I receive the patients after ICU admission, the first is to avoid RT. In patients who do not need RT, avoid RT. If necessary, I prefer intermittent because it's better for transportation, surgery, etc., etc. Before vasopressor weaning, I think that we can use both. But after vasopressor weaning, there is two possibility. High fluid overload, I prefer to use continue for gentle ultrafiltration 24 hours a day. But if you need rehabilitation, I prefer to use intermittent hemodialysis. Thank you very much for your attention.